So today is the John and Cynthia Schulze Visiting Professorship. And just a few words about John and Cynthia before I introduce our speaker. John and Cynthia were both very connected to the University of Colorado. John attended the University of Colorado School of Law and then went into the practice of oil and gas law in the state. He was a big supporter of the law school, and there's actually an endowed professorship in the law school in his name too. And Cynthia spent her entire career doing administrative work on the Boulder campus and served in multiple leadership roles in the graduate school on the Boulder campus. And the two of them went to every CU Buffaloes game along with Peggy, who celebrated her 103rd birthday this year. They established this visiting professorship because they were the benefactors of multidisciplinary care here on the Anschutz campus, and they wanted to encourage collaboration between disciplines. And with that in mind, I think our visiting professor this year is a perfect person to be the Schulze visiting professor because she's worked in an extremely broad field within surgery, touching almost every discipline. So to introduce Gretchen Schwarze, she's a professor, she's the Moorridge Professor of Surgery in Vascular Surgery at the University of Wisconsin. She did her MD degree at Harvard, and then while she was there, she also did a master's at the John F. Kennedy School of Government. She did a residency in Boston at Massachusetts General Hospital, and then did her fellowship in vascular surgery, as well as a fellowship in ethics at the University of Chicago before she became an assistant professor at the University of Wisconsin in 2007. And then she has climbed the academic ranks to become a professor with tenure in vascular surgery in Wisconsin. She also has a joint appointment in the Department of Medical History and Bioethics, and she leads the ethics committee and the ethics program at the University of Wisconsin. I could go through all of her publications and chapters and all of that, but I think one of the more important things when you look at her CV is that she had her first grant in 1998 and has been funded ever since, and currently has 2 R01s and a K-24. But she's a great mentor, having mentored 10 K mentees over the years. And when you look at the topics that those mentees have worked on, they're as broad as being thyroid cancer, renal failure, ICU care, geriatrics, lung cancer. So you can see how her work has just touched on so many different areas of surgery and expertise. And with that, I'd like to welcome Dr. Schwarze.
All right, I think so. How's the audio? Is it okay? All right, my voice is a little high and squeaky, so if it gets too high, tell me just to turn it down a little bit. I cannot tell you how excited I am to be here. I have so many friends here, and I've never been here before. I've been to Denver about 1 million times, it seems like, but I'm just absolutely delighted to see your medical center and see so many people that I know and care so much about. Before I get started here, I just want to thank the NIH for supporting now an enormous amount of my salary, and we're all supposed to disclose this at the beginning of our talks. But I think there are other things you might want to hear me disclose that are important to say as well. So the first thing you will notice is that I am a surgeon first and a bioethicist second. And so you will see that I'm actually pretty pro-surgeon. That's my lens, and I think it's really important to say that. The other thing I will say is that what I'm going to talk about today is what I think is sort of a failure of bioethics. And that doesn't mean a failure of the people you know who are bioethicists, but the discipline as a whole that came up with some really great ideas about informed consent in the 50s and 60s, and then never did the empirical work to find out how these things were playing out clinically. And so what I'm going to talk about today is that I think we are actually doing a pretty good job with the communication strategies we've been taught to talk to patients and families about surgery, but we never evolved from the 50s and 60s, and we need new things to help us do better. There's this awesome Seinfeld episode where Jerry has a friend who converts to Judaism so he can tell Jewish jokes. And someone says to Jerry, "Does that bother you as a Jew?" And he says, "No, it bothers me as a comedian." And I think like being a bioethicist gives me a little privilege to talk about my group, but I want to be really clear that I'm not talking about anyone you actually know. And then finally, I'm going to try to present some solutions, but I want to be clear that these are not the solutions to all of our problems, just maybe a start. So the first thing I'm going to talk about, I have three different things. The first thing I'm going to talk about is our intervention called best case, worst case. It's maybe an intervention you've heard of before, and I want to say that it's really great for some settings. And those are settings when you're really on the fence about what to do, where there's high uncertainty about what the outcome is going to be, and where the treatments are very burdensome. And you may be so on the fence that what you're looking for is trying to pick the least worst option. There's this awesome quote, and it goes something like this: "If I don't show you data, you won't believe me. But if I don't tell you a story, you won't care." So I'm going to start with a story. My story is about a patient who came to our hospital in Madison now several years ago. She was in her late 70s, and I think all of us might have described her as frail. She had a tender thoracoabdominal aneurysm. She had a baseline creatinine of about 2.5, and she was on home oxygen. She had a wonderful supportive family and was just barely making it at home with a walker with her family support. And my colleague sat down and had a very long conversation with her about whether to pursue surgery. He said, "You know, if we do surgery, you have a 50% chance of dying. If we do surgery, you have a 60% chance of being on dialysis afterwards. And if we do surgery, you have probably an 80% chance of being stuck on a ventilator for much longer than you would like." And very appropriately, he offered her an alternative of comfort-focused palliative care. She and her family thought long and hard about what to do, and ultimately they decided they wanted to move forward with surgery. So the next day he took her to the operating room. They cut her from here to here, 10 hours in the operating room. Case went pretty well. The following morning, the surgical team came and rounded on her, and she was holding her own. She was making a little bit of urine. She didn't have much blood transfusion requirement. She was as best they might hope for. A few hours later, her family came by, and you know exactly what they saw. She had tubes sticking out of everywhere, a huge row of drips running behind her. She was puffy all over. She could not even squeeze their hand. And they took one look at her and turned around and said to the ICU team, "No, this is not okay. She never would have wanted this." And they asked the team to withdraw all of her life-supporting treatments. So if I had to tell you what happened to this patient, I would say she received unwanted care. But if I had to describe why it happened, I would say that the way all of us have been taught to get informed consent, where we use disarticulated probabilities to describe the consequences of surgery, is not working. Because you can understand exactly what this family did. If she had a 50% chance of dying in the operating room, she had a 50% chance of not dying. She had a 60% chance of being on dialysis. She had a 40% chance of not being on dialysis. And an 80% chance of being stuck on the vent, and she had a 20% chance of not being on the vent. And they went right down the list, 50, 40, 20, and thought, she has a 20% chance of being exactly like she was before surgery, after surgery, when I know there is not a person in this room who would have thought that to be true. And so I worry that these strategies we've all been taught, they are not working for us, but worse than that, they are not working for patients and families. So how might we do better? So we developed an intervention called best case, worst case. It's two things. The first is a graphic aid. It looks just like this. It's a simple pen and paper diagram. There are two lines. Each line represents a treatment option. The star at the box is the best case scenario, and the box at the bottom is the worst case scenario. And the oval represents what is most likely. And we use this diagram to help patients and families remember what we're talking about. And you can see for this patient, the options would be surgery or comfort-focused palliative care. But more important than the graphic aid is this idea of scenario planning. This idea that in order to anticipate and prepare for the experience of surgery, we need to tell a story about what it looks like when things go well. So what might we have said about this patient who I just told you about? In the best case scenario, she would need to go to the operating room. She would be there all day. After being in the operating room, she would go to the ICU, and she would need a lot of support in the ICU, like a ventilator and lots of medicines. And she'll have tubes coming out of her nose and her chest. If we are lucky and everything goes well, she'll be in the ICU for probably 5 or 6 days. Then we'll get her out of the ICU, and she'll probably be in the hospital for another week or 2, getting her strength back. And given what I know about her, given that she was just barely making it at home before this major operation, I could imagine that she might go to a nursing home after surgery, but I have a really hard time imagining, even in the best case scenario, that she is going to make it back home anytime soon. And I suspect she'll need nursing care for the rest of her life, 6, 12, 18 months. What's the worst case scenario? Well, probably like me, my worst case scenario is that the patient dies in the operating room. But this is not the worst case scenario for patients and families. What is worse is that we take them to the operating room, and then they go to the ICU, and complication after complication after complication builds up, and 3 weeks later, we decide to withdraw life-supporting treatments. Once you have placed boundaries around the limits of what is possible, you can talk about what is most likely. For some patients, it's actually pretty close to the best case scenario. For this patient, what is most likely is probably much closer to the worst case scenario than we might hope. And we can do the same thing for comfort-focused palliative care, or another option. It's not always comfort-focused palliative care as the alternative. So I'm just going to go quickly through the steps of how to do best case, worst case, so you can use it yourself. The first thing I have is a video, and I play this video, or I try to play the video.
No,
oh, stop,
Rose.
Hold on. Woo! Total technical failure. I promise I'll go back to the video. The reason I play this video is that I worry that people are a little nihilistic about best case, worst case. And I want to remind us that surgery can do a lot of good things. And what we're trying to do is figure out whether surgery is right for this patient. So here we go. I'm not liking this clicker. So much for promises.
No, Rose, they are not breathing, and they have no arms or legs.
No, that's not part of it.
Where are they? You know what? If we come across somebody with no arms or legs, do we bother resuscitating them? I mean, what kind of quality of life do we have there?
Yeah. So don't use best case, worst case to be nihilistic. Surgery can do lots of good things. So what are the steps? How do we use it? Well, the first step is that we need to break bad news. And when we did our original studies, we found that surgeons would walk into the emergency room, see a 92-year-old lady with an newly diagnosed obstructive colon cancer and say, today we have a choice between surgery and hospice. And the patient would be like, what are you talking about? I was fine yesterday. And so we need to break bad news that even with surgery, things may not go the way we want them to. The second step is to create the graphic aid. And many of my surgeons will say, I can't find paper in the hospital, just steal it out of the printer behind the desk. It's a simple pen and paper diagram. And I will be honest with you that even I, a big supporter of best case, worst case, do not always use the diagram. But this is really helpful for patients and families. When we did our original study, we would go to people's houses and unprompted, they would grab this graphic aid out of a drawer and say, when we were in the hospital, the surgeon gave us this, and it was really useful. So just to look at these graphic aids, what did they look like? This was from our original study. This is a 90-year-old farmer who came in with 4-foot sepsis, and we talked to him about baloney amputation or going home with hospice. This is a patient I took care of and saw in the emergency room with recurrent mesenteric ischemia. You can see I've uploaded it into our FACS system so that everyone can see it. And we talked to him about surgery or hospice, and he ultimately chose to move forward with hospice. The next step is this idea of telling a story. And this is the hardest part because it is a new skill for us. We are not used to doing this. And I think this is the challenge where sometimes best case, worst case falls short because people don't understand how hard it is to think about a story that has a beginning, a middle, and an end. But you can think about it. The first part of a story about having surgery is you have surgery. Then what's the recovery like? What kind of other procedures might you need? Where are you going to go after surgery? What is your function going to be like? What does your overall health trajectory look like? That's what's in this story. And I think the challenge with best case, worst case is it sounds intuitively pretty easy to do, but I will talk to people and they'll say, oh, I love best case, worst case. I use it all the time. For example, I just told this lady in clinic yesterday, in the best case scenario, she has an 80% chance of dying in the operating room. I'm like, that's not it. So you have to really think about these stories and then tell them as you move through the best, worst, and most likely scenarios. The fourth step is called elicit preferences, and I will tell you that this is the hardest step, and this is a step that we might want to ask our colleagues in palliative care to help us with, particularly when we're struggling. And the challenge for us as surgeons is we want people to make a treatment choice, right? When we ask them, what do you want? We want them to tell us what to do because we need to know what to do next. But in fact, what we want to hear is what is valuable to them. What is a tolerable health state? What burdens of treatments are going to be acceptable? And so when we did our original study, the patient would say something like, I just want to live. And the surgeon would say, great, let's go do surgery. But the surgeon had never heard whether it was okay to live in an LTAC with a trach on dialysis, that kind of thing. And I think the challenge with eliciting preferences is you want to hear, what do you think about what I just told you in the best case scenario? Is that okay for you? I also think we're often having these conversations with surrogate decision makers, right? Somebody who the patient can't talk to us and we're talking to their loved one. And we say, well, what would she want? Well, that is a very aspirational question. And we might want to change that phrasing and say something like, what would she think about being in the ICU for another week or two if we did surgery? What would she think? Or what would she say if she could tell us? So finally, the last step is called make a recommendation. And again, this is where I'm going to get on the bioethicist, because when we taught our surgeons how to do this originally, we would get to this point, they'd do a beautiful job, and we'd say, okay, great, now make a recommendation. And they'd turn around and look at us and say, I can't. My job is to offer choices. Their job is to choose. And I think that's a real misunderstanding of what it means to make an autonomous decision. And I would say that that's something I might call absolute autonomy. And I think what the bioethicists need us to understand is something like relational autonomy, which is that all of us have relationships in our lives where we have experts that help us make decisions, whether it's your auto mechanic or your financial planner or your clinician. And we expect those experts to use their expertise to help us make a decision. So we have, surgeons on audio recording, and the patient or family will say, what would you do if this was your dad? And the surgeon will say, I don't know. He's not my dad. Don't say that. Say something like, it sounds like you're looking for a recommendation. So how can we do that in a way that respects their autonomy? Well, we've just heard from them what is valuable to them, right? This idea is that I am setting this whole conversation up so I can understand what you are going to be able to tolerate and whether this health state I can get you to after surgery is worth it to you. So now that I've heard this, I can make a recommendation. Given what you told me, this is what I think we should do. Think about it. If you went to your financial planner, the last thing in the world that you want to see is 20 different portfolios of stocks and bonds and tons of education about stocks and bonds and have them say, you choose. You know what I want my financial planner to do for me? I want my financial planner to say, Gretchen, this is what I know about you. You want to retire at age 65, you have 2 kids to get through college, and you are very risk averse with your money. Given what I know about you, this is the portfolio you should be in. I think we can do that, right? I just listen to the patient and family about what I know about them. Given what I just heard, about going through all of these things and being in the ICU and how that is not okay with her, I think we should go this other way and go comfort-focused palliative care. Or reverse, I think we should do surgery, given what you just told me. Given what I know about you, this is what I think you should do. And if they're still asking you for a recommendation and you don't feel like you know enough, you could say something like, I would love to give you a recommendation, but I need to hear a little bit more from you about what's okay in order to do that. All right, so I'm going to switch gears because I have 3 things to talk about here. So the next thing I'm going to talk about is better conversations, which is our new strategy for informed consent. So best case, worst case, I told you is for very specific settings. Better conversations is for any conversation that you're having with a patient and family about surgery. And the quote that goes with this is, I believe it's from Einstein. The quote is something like, if I had 60 minutes to save the world, I'd spend 55 minutes trying to figure out what's wrong with it. And so I do think that when we're thinking about research, getting really strong observational data will show you where we fall short, and we'll come up with a much better solution than just taking some solution off the counter or off the shelf and trying to apply it when you don't understand the situation. So I'm going to talk about our observational data and tell you that for the last 10 years, we have been audio recording surgeons talking to patients and families and interviewing patients and families before and after surgery about their experience. And patients and families almost universally tell us 2 things. The first is they felt like they had no choice, that surgery was the only option. And the second thing they say is that they felt very blindsided by the experience of surgery itself. So here's what the audio recordings are like. And I will be honest, this is an enactment, but it's pretty accurate.
What exactly are leg ulcers?
Well, quite simply, a leg ulcer is the consequence of tissue hypoxia following on ischemia due to venous stasis, evidenced by proximal varicosities and incompetent perforators, or of course due to arterial insufficiency. There's full-thickness epidermal loss, eschar formation, in your case, probably anaerobic infection. You're going to need debridement, occlusive dressings, antibacterial and non-adhesive applications at least 3 times a week. Nurse will organize it. And I'll see you again in 6 weeks. Are there any questions?
Nope.
Are you sure?
Yep.
Fine. Then I'll see you in 6 weeks. Bye-bye.
Bye-bye.
Well, we don't have any Monty Python in our cohort, but we do have 600 surgeons from all over the country talking mostly to older adults about major operations. And I will tell you, all of us do it pretty much the same way. The patterns of preoperative communication are incredibly robust. We all start with some story of, let me talk about your disease. We show them CAT scans. We say, this is you, slice like bread. How many people say slice like bread? Yeah. How many people say slice like ham? We have a few in our cohort, they say slice like ham. It doesn't really resonate with me. It seems weird, right? They say, this is you, slice like bread, and this is your liver. And this white spot in your liver, this is a tumor, and I'm gonna take it out. All of us do this. This is your problem. And we go into incredible detail. I have this beautiful esophageal surgeon in my cohort, and he says, he starts every conversation with, your esophagus has 3 layers, the mucosa, the submucosa, and the muscularis, right? And then we go on and we talk about our operation to fix the problem. We draw beautiful diagrams. I myself am quite good at drawing an upside down aneurysm with a stent going through it, but we all do this. This is your problem, and this is the operation I have to fix it. And we may go on to say, well, maybe it's too broken to fix, or maybe it's not the right problem to fix, or I can fix it, but you will never be the same again. But we have already started at the beginning of this conversation with a story of, this is your problem, and I have an operation to fix it. And I will show you what the data looks like. This is the data. Now, I have about 10 HPV surgeons in my cohort, and I think every single one of them has come up to me and said, that's me, right? It's not, I don't know who it is actually, but if you read this, and I'm not expecting you to read it, it is the most beautiful description of a Whipple that you have ever seen. It actually uses fairly patient-friendly language. It's all done in one breath. We didn't cut out the family or the patient's comments in here. It seems to come with a diagram. But this is the problem. This takes a lot of time, and it's not clear to me that you need to know how to do a Whipple in order to figure out whether you want one. It's as if a plumber has come to your house to fix your toilet, and they have spent a ton of time talking about the flush valves and the gasket and the beauties of fluid mechanics, and they have not once said to you, how much is it going to cost you? How well is your toilet going to work? And how long is it going to last? And I worry that this is done with the best of intentions, but it is not helping patients and families, because I will tell you, I probably did 5 or 6 Whipples as a resident before I had any idea what was happening in that operation. So it is unclear to me how a patient who is scared and sick in 20 minutes can learn anything from this that's going to help them figure out whether surgery is valuable to them. And it takes a lot of time. So when we quantitated out the data, the orange and the pink pie pieces, that is the time we spend in this is your problem and this is the operation I have to fix it. And all of these other things that we might want to talk about, like the goals or expectations or uncertainty, that gets squeezed into the little time that is left. We also looked at the goals of surgery, and surgery can only do 4 things. It can help people live longer, it can help them feel better, it can help preserve function or prevent disability, and it can make a diagnosis. That's it. When we quantitate it out, we find that more than 50% of the time, no goal is mentioned. The only goal is that surgery is going to fix their problem. And 25% of the time, the goal is that it's going to cure or control their cancer, which I will admit sounds completely awesome. And simultaneously, if that doesn't actually help you live longer or feel better, it doesn't matter, right? It has to do one of those things in order for it to be valuable to patients and families. And so I worry what happens is that we are not actually having a conversation about what surgery can and cannot do for patients. I had this very lovely 96-year-old gentleman come to my outreach clinic in Wisconsin, and he had a 6-centimeter aneurysm that was found on his preoperative workup for his TAVR, and the cardiologist was like, oh, Gretchen, you better fix this right away. And I looked at this guy and I was like, you know, the only reason to treat your aneurysm is to help you live longer. And he looked at me and he goes, I don't want that. We need to be precise about what it is that we're trying to do. I will often start a case and say to the resident or the student, why are we doing this operation? And they'll say something like, the ABI is 0.3. I'll say, well, why are we doing this operation? They'll say, well, the patient has a blockage in the superficial femoral artery. Why are we doing this operation? The patient has peripheral vascular disease. It takes maybe 5 or 6 questions to get to keep the patient from losing their leg or to help the patient feel better. And the challenge is, like, this is how we think, and that's okay. When we think about amongst ourselves about what we're trying to do technically, but when we don't make the connection between what we're trying to accomplish technically and how it's going to impact the patient's life, we haven't really gone through it with them in a way that can figure out whether it's valuable to them. It also can create some misunderstanding. I don't know how many of you have seen this video. I don't have a video in my slides because it's just so popular. So many people have seen it. But the little blue stripy bear is the orthopedic surgeon, and the red stripy bear is the anesthesiologist. And the orthopedic surgeon says, I have a fracture. I need to fix it. And the anesthesiologist says, well, where is the fracture? And the orthopedic surgeon says, it's in the emergency room. And it turns out the patient actually has something he's never seen before, asystole. But the challenge of this language of we can fix your problem is it can create misunderstandings. Many years ago, they did a study in JGIM, actually, but they were in the UK, and they asked patients who were waiting carotid endarterectomy about the surgery. And they said, what are the risks? And very appropriately, the patients knew the risks. They said, you know, I could have a heart attack or a stroke or nerve injury. That seems pretty good to me. Then they asked what the benefits are. And for the most part, they came up with it would help prevent stroke. And then they said other things like, well, my memory will get better. And the ringing ear, my ears will improve. And my shortness of breath will get better. And for those of you who don't like vascular surgery, it doesn't do those things, right? The only thing carotid endarterectomy will do is help prevent stroke. So how did these patients get that wrong? They were told that they had a blockage in their neck artery and surgery would fix it. And they were not told that the only reason to do surgery is to prevent stroke. And as such, they attached their own goals to the operation. So we need to be really precise about what surgery can and cannot do to avoid these misunderstandings. I have a lovely colleague who does a lot of inguinal hernia repair. He says a lot of his patients think that their impotence is going to get better with their inguinal hernia repair. So we need to be really careful about this. So the last thing our data shows is that when surgeons are reluctant to operate, we actually score much higher on shared decision-making, on measures of shared decision-making. And what happens is that we offer choices, and then we surreptitiously push people away from surgical intervention. And you can see how this goes down. This is an 87-year-old gentleman who's seeing a surgeon about cystectomy for his bladder cancer. And the surgeon says, yeah, it's a pretty risky operation. And I've done it before on an 85-year-old guy, but he was like climbing Mount Everest. Like that is some sort of signal that if you're an 87-year-old guy and you can't climb Mount Everest, maybe you shouldn't be having a cystectomy, right? We should be more directive about what we think about whether surgery is a good idea or not. And that when we're not transparent about our thoughts, patients and families are going to be prone to misunderstand things. So let's just summarize sort of this core framework of informed consent, which I think all of us understand pretty well because we use it every single day, which is that this idea that patients need to understand their disease and treatment, that the benefit of surgery is that their problem will be fixed. If you look at our data, surgeons are actually pretty darn good with risks. All of us do this every day, bleeding, infection, stroke, heart attack, death. We're quite good with risk disclosure. We offer these non-choice choices and then move forward with surgery. So the question is, how could we do better? So I'm going to go through each one of these steps, but I just want to say that this is our new intervention. It's called Better Conversations, and it takes each of the problems that we saw in our data and addresses it head on. The first step is called Show Your Cards and be transparent about what you think about surgery. The second is to name the goal. It has to be at least one of these four things. The third is that there are more downsides to surgery than just the risks, but really the step we care about is getting patients and families to deliberate between what we are trying to accomplish for them, is that valuable to them, and is it worth going through all of these downsides so we can come up with an agreement and a plan. If you can't get the QR code to work, the video comes up if you just Google Better Conversations whiteboard video. All right, so the first step is this idea of show your cards. And this is a moment to be transparent about where you are coming at surgery from. It is your opinion, not your recommendation. And the way I think about this is that we are not going to ask a 45-year-old gentleman, we're not going to go in the room and say, hey, with colon cancer, and say, hey, today we have a choice between surgery and hospice, right? What we do for that patient typically is surgery, and we should say that. So we did a big survey of surgeons across the country, and there are surgical norms around things that we almost always operate on. There are certainly things on the other end of the scale, like an older adult with multiple comorbidities who's not going to do well with surgery for their aneurysm. And then there's something in between where there clearly are two reasonable treatment options. We should at least set the table by giving them a starting point. It is a way to contextualize the decision. So what would that look like? On the right side is things that we almost always do surgery for. On the left side are things that we're hesitant to do surgery for, and then what we call equipoise in the middle. So for things where we usually do surgery, we should start that conversation by saying something like, typically we do surgery for this. Right? That's not my recommendation. That's me saying, like, I just want to tell you what the landscape is. This is what we usually do. Or you could start by saying something like, I think surgery will help you. When you are reluctant to operate, I think we should tell them that. I'm worried surgery is a bad idea. That doesn't mean you won't operate. It just means you need to give them the heads up that this may not go the way we want it to. And so we need to be on the same page about that. And then finally, this idea of being in the middle. Right? I think it is very hard on patients and families where we show up and say, we have a choice to make. Because they're like, whoa, wait, aren't you the doctor? Aren't you trying to help me make a choice? And it might be easier to start that conversation by saying something like, I'm really on the fence. There are two ways to do this, and we need to talk about both of these ways so I can figure out what's right for you. And sometimes I think there's really true community equipoise, and you personally are not on the fence, but you could still start that conversation the same way. There are two ways to do this. I think one way is better than the other, but I want to talk about both of these things because one may be better for you. So let's talk about both of these ways. The second step is to name the goal, and it needs to be one of these four goals so that we don't mislead patients about what it is we're trying to accomplish. So again, it's live longer, feel better, or improve function. It's a pretty big bin. There are a lot of different things that we can put in here. Preserve function or prevent a disability, or make a diagnosis. And I think we can be more specific about that. I was doing this with the vascular residents the other day, and we were talking about a patient with gangrene in their foot. I was like, well, what's the goal of surgery? And they said, to prevent a disability. I'm like, well, could we be more specific? Yeah, the goal of surgery is to keep you from losing your leg. I also think that we need to use this step to talk about what surgery cannot do so that we don't mislead patients. You know, I see a lot of patients with varicose veins. They come in, they're scared to death about their veins. They see all these commercials for Eliquis on TV, and they think they're gonna have clots and this terrible circulation problem. It's really important to say, the only reason to treat your veins is to help you feel better. I am not worried that these veins are gonna take your life. I am not worried that these veins are gonna take your leg. I gave a talk like this in New Jersey a few weeks ago, and there was a lovely thoracic surgeon who emailed me a few days afterwards. He said, Gretchen, I thought I was really good at this until I saw a patient in clinic today. It was an 85-year-old woman who he had done a hiatal hernia repair on, and he said that all of her reflux symptoms were totally better after surgery, and she was incredibly disappointed about her surgery. And ultimately, after asking her a few questions, he found out that she thought her reflux surgery was going to treat her fecal incontinence, and it had not. Shocking, right? And the challenge with that is that she thought she was having surgery on her abdomen, on her intestines, and that her intestinal problems will get better. And I think that, you know, this story of like, we found this hiatal hernia and surgery is going to fix it is a story that if we don't listen to what patients and families are hoping for with surgery, and we're not clear about what surgery can and cannot do, they can take on surgery for reasons that actually aren't valuable for them, or reasons that are valuable to them, but they're disappointed because they had other hopes about what surgery could do for them. And so we need to be precise here. So the third step is to name all the downsides of surgery, recognizing that there are more downsides to surgery than just the risks. So we have this mnemonic, and the mnemonic is the bin of bad shit has 3 layers. I swear to you, I sent a paper to JAMA Surgery with this word in the title, and they won't publish the word. Apparently you can't say shit in JAMA. And I wrote back and I was like, I'm pretty sure surgeons have heard that word before, but you still can't say shit in JAMA. So it doesn't say that. But I think it's a really helpful mnemonic to try to remember all of the things we want to talk about when we're talking about the downsides of surgery. So the first thing is this idea that it's not just things that might happen, but things that do happen to everyone who has this operation, which is you have to have surgery. Surgery hurts. Even little operations have some recovery time associated with them. If you have a lap chole, you are not going to be playing pickleball the next day. You are not going to feel good. You'll probably have loose stools for about a week, but within a week or so, you feel pretty good. If you have an esophagectomy, that story is totally different, right? You're going to be in the hospital for probably a week or so. You cannot actually eat for a while. When your recovery is going to take about 2 months, and you're never actually going to be the same again, right? When your stomach becomes your esophagus, you are not the same person you were before surgery. And that doesn't mean surgery isn't valuable to you. It may be absolutely worth the trade-off, but these are the kinds of things people need to know, not just to figure out whether they want to have surgery, but also to go through it. When you can anticipate and prepare for the experience, it is much easier to get through. The second layer is this idea that there are bad things that could happen. Again, we're all pretty good at major complications, bleeding, infection, stroke, heart attack, death, but there are other things that we don't think of as complications and we don't mention them. So the first is this idea of bumps in the road. Like I will tell you, if you went to the vascular surgeon service at the University of Wisconsin right now, 40% of our patients are in urinary retention, right? It is such a common bump in the road, and it's really annoying. You could imagine like post-operative delirium, if you went into the room to see your loved one of you've been married to for 60 years, and they're flying off the wall totally confused. How much easier would that be if you could think in your mind, you know, Schwarze said he might be a little confused after surgery, and usually it gets better. My husband's a transplant surgeon, and he did a laparoscopic donor nephrectomy and sent the patient back up north 3 hours away from Wisconsin, or from Madison. And she had shoulder pain. Shocking, right? Very common bump in the road after laparoscopic surgery. She has shoulder pain. She goes to the emergency room. What do they do in the emergency room? They get a CAT scan. What do they find? Free air. Shocking, right? They send her all the way back to Madison for a bump in the road that we probably could have prevented by just mentioning that sometimes after surgery, people get shoulder pain and it gets better. There are also major functional changes that I think many people would be happy to take on in order to achieve the goal of surgery, but would be much better to do this calculation themselves in advance. So for example, as a 55-year-old woman, if I had colon cancer, it seems very reasonable to me to take on the chance that I could have chronic loose stools for the rest of my life. And if that happened to me, I would not be happy about it, but I would think it was worth the trade-off of being able to live longer from my colon cancer, but I would want to know that in advance. I would want to do that calculation myself. So if it happened to me, I could be like, yeah, this sucks, but it was worth it. Reportable complications, again, we're good at this. And then finally, this idea of totally unexpected events, which is that every time I operate on somebody, I know I expose them to something in the hospital or the operating room that I cannot predict. And I just say that. That is part of the calculus about whether surgery is valuable to you. The third layer of the bin of bad shit is that we fall short. And you can tell from our data that none of us do this, right? Even when surgery goes well, we still might not meet our goals. What does that look like? We do a beautiful Whipple procedure. The patient recovers beautifully 2 months later. 6 months later, they come back to the office and their post-op scan shows cancer is back, right? We failed to meet our goals. We operate for back pain. The surgery goes beautifully. They still have back pain. How does it look like on my service? We do a gorgeous, beautiful bypass. Looks awesome for about 3 months. And then 4 months later, we're having the same conversation because the graft is down, having the same conversation about what to do about this ischemic foot. Surgery can fall short. So once we've set this up, right, we've given them context, we've told them the goals, and we've talked about the downsides. And you will note, none of these steps are draw diagrams or talk about the disease and treatment, right? We start by saying, you have an aneurysm. Let's talk about how best to take care of you. Typically, we do surgery. The reason to do surgery is to help you live longer. We talk about the downsides, and now we need to ask them to deliberate with us. Is it worth it to you? How are you thinking about this? Are you willing to go through all of this in order to meet this goal? And if you talk about when you're worried about surgery is a bad idea, you will give them a rationale. I'm worried it's going to feel you'll fall short. I'm worried you won't be the same again. Does my reasoning make sense to you? Because ultimately we want to go forward with an agreement and a plan, and we want to hear from them what it is they're hoping surgery will do, and that surgery for them is tolerable. And so you might say, if you're talking to somebody about cholecystectomy, you know, they say, oh, I can't go out to eat with my friends because I'm just getting this pain after eating. It makes sense to me that we should do surgery for you because it's really bothering you. And you're willing to go through all this in order to feel better, right? Confirm with them why we're doing this operation. Some patients may be curious, so I'd want to be sure that you don't think that Gretchen says don't ever draw pictures and don't tell them what the operation is. That is not what I'm saying. What I'm saying is that once you've decided to go through it forward with surgery, some patients, not all patients, may be curious. And this would be a time to draw the pictures and show them what you're doing in the operating room. You will find that if you get through this whole part, there are actually not that many people who want this. So I have told you a lot of things here. And I will tell you that oftentimes when I explain what better conversations is, surgeons say, yeah, I already do it that way, which is a little annoying. But it's also great, right? Because it means they think it's the right thing to do and they think that they can do it. I will challenge you to just pick one thing that I talked about today that you want to try the next time you see a patient and family to try and see if you can use better conversations yourself. I think one of the biggest challenges to changing communication is that many people think that they are already very good at communicating. And I will tell you, if you think you are good at communicating, I agree with you. I bet you are actually really good at the things that we were taught to do. And the challenge is that the things that we were taught to do just don't work very well, and they're old-fashioned. What do we do in surgery? We innovate, we evolve, we try new things, new techniques. Try something new, see how it works. So the last thing, my third thing, it's really short, is this idea of attending to emotion. And again, I'm going to get on the bioethicists because they have this sort of strategy that we're all making rational decisions all the time. And if we could just have a good rational conversation about what to do, everything will be fine. And I'm sorry, but if we are talking about surgery, we have already lost the game in a rational decision because even small surgeries are scary to people, right? People are worried, people are angry, people are mad, they are scared. There is a lot of emotion going on when we are talking to patients and families about surgery. And we need to learn how to manage this because when people are in a high emotional state, it is very hard to have a rational conversation about what to do. So all my colleagues in palliative care are sitting here in the front 2 rows. We should learn from them, right? They have these awesome tricks to address emotion, and it will allow us to help our patients and families attend to their emotion and then move forward in a space where we can have a rational conversation with them. So what does it look like? So the nurse mnemonic is a very helpful way to think about how to address emotion, how to attend to emotion. When people are being emotional with me, I am pretty emotional myself, and the only thing I can remember is the N, which is to name the emotion, right? And what does that look like, right? You come to see somebody 5 days postoperatively and they have a leak from their anastomosis, and they are, why did this happen? What is going on here? What do you say? This sucks, right? That is an emotion we can all share about someone who is now having a terrible postoperative complication. This sucks. This is so upsetting. What is an understanding statement? Well, that's validating, right? We need to validate their emotion. It makes complete sense to me that this would be upsetting. I absolutely understand why you would feel like this. What's a respecting statement? Now, that's like a praise statement. Somebody comes back, their cancer has recurred, they're very upset. You have been an awesome patient. You did everything we asked. We have patients in the ICU, right? They're there, the daughter's sitting next to the mother's been there for weeks. Suddenly she's got free air, and the daughter looks at you and says, why? Why did this happen? She was fine yesterday. The answer to why did this happen is not a long conversation about seeds and muscularis mucosa and diverticular perforation, right? The answer to why did this happen is, this sucks. Clearly you love your mother so much. You've been here every day taking care of her. A supporting statement is, I'm here. I'm here and I'm going to take care of you. An exploring statement, tell me more. Tell me more about what you mean when you say your mother is a fighter. So the last trick from our palliative care colleagues, does it project? Okay. The last trick from our palliative care colleagues is this idea of how to handle questions like, isn't there anything else you can do? And I will tell you that as a surgeon, that is such a ridiculous question because I can always think of something else I can do. But the answer to isn't there anything else that you can do is not, sure, I can do a 4th time redo bypass with PTFE to below the knee to a really shitty target vessel, right? The answer to that question is, I wish, right? These skills exist. These tricks work. We can learn from our colleagues in palliative care and use them so we can have better conversations with our patients and families. So hopefully I've left enough time for questions here. I want to say a few things. First of all, you cannot be from Wisconsin without showing a picture of Bucky Badger. You also can't do all this work without a huge team of people. There are a bunch of online resources. The Vital Talk group has taken over best case, worst case, and they have some wonderful asynchronous training programs that you can do. And then finally is trying to think through dissemination of this. Our group is working on a fundamentals of communication in surgery project, and we're piloting that with the support from the Macy Foundation. So if you are interested in the fundamentals of surgery, this QR code or the link will get you to our interest group site so that we can keep disseminating these things. So I've left, I think, 9 minutes for questions. As a surgeon and bioethicist, you'd think I have pretty thick skin. I really don't. So I may have said some things that are controversial, and I'm happy to answer questions, but don't throw anything at me. That's it. Thank you very much for inviting me.
Actually, at noon today, Dr. Schwarze is going to be talking about the fundamentals of communication in surgery over in the 6th floor of the AO1 building for residents, students, and fellows. So please attend if you have the ability and free time. Dr. Schulich.
So Dr. Schwarze, thank you so much for visiting. I enjoyed your talk. You know, we deal with this every day. And I think you're right. I don't do this perfectly, and there's a lot of room for me to learn, and I'm sure most of the audience feels the same way. There's one aspect that I have used, and I'm wondering what you think about this. So if I know that there is a high-risk operation or things may not turn out the way folks want, I actually try to use time and relationship. So I typically won't do a very, very risky operation or something where, it's a little bit of a sketchy indication without meeting that patient at least a couple of times before going to the operating room. And I've just found that by doing that, things go better. The other thing is, we typically have, whatever it is, 15 minutes, 30 minutes, an hour to see a patient. And that's an artificial constraint. And the other strategy I sometimes use is, look, I'm going to tell you what I think we should do, but I don't want you to make your decision right now. I want you to go home and think about this and then come back and see me after you've thought about this, investigated, or further talk to your other family members or whatever. So I think time is an ally for a lot of these difficult situations.
Yeah, I love that. And I think the way I think about time, and I think we can see time in the hospital do the same thing, that is actually changing the emotional valence of what is going on. Because you can imagine that in the acute moment when they first meet you, the emotional tension is very high. But now that we have time to think, we can be in a more rational space. And you think about it in the hospital, this happens on the vascular service all the time. People will come in with a bad forefoot wound, and we talk to them about amputation. And what is the first thing they say? No, never. I'd rather be dead, right? Right now, having an amputation sounds like the worst thing you've ever heard, right? This sounds horrible now. But I'm going to give you some time, and we do, we literally admit people and give them time in the hospital, basically to help them emotionally, because it is scary and it's very hard to imagine what it would be like. And I think that's brilliant that you do that with your patients in an outpatient way. I'm sure that there are pressures, economic pressures that make that difficult. And I think you're spot on correct about how useful that is. And I think that's why it's awesome.
Dr. Robinson.
Schwarze, thank you. Your work is inspiring. I appreciate you, and thank you for coming to the University of Colorado. What if somebody was to say that the solution is a multidisciplinary approach rather than an individual patient approach, similar to kind of a tumor board? What do you think about that approach?
Well, I mean, far be it from me to strike down tumor boards. That seems like a great idea. And clearly it's working very well for multiple different things. I worry a little bit that and a lot of solutions have come up around consent and communication that take the surgeon out of the equation, right? Whether it's a decision aid or having somebody else do the conversation. And I will be honest with you, like I will be in groups and somebody will raise their hand and they'll say something like, why are you teaching surgeons to do this? Shouldn't we just get someone who's good at communicating to do it? And my feeling about that is A, it's like kind of insulting, but B, it takes a surgeon about 2 seconds to undo anybody else's work, right? And so all of these other people who are working so hard to help patients make a decision, the surgeon will walk in, like I can see the whole palliative care group, they're just nodding, like they have been there so many times. The surgeon will walk in and undo everything. I also think that all of us went into surgery for lots of reasons, but one of the big reasons is because we like people. We like having these conversations and we like thinking about whether surgery is the right thing to do here. And if all we cared about was the technical aspect of surgery, we would have gone into aerospace engineering. So to totally cut the surgeon out of the loop and have some other group do it seems unfair. I think, Tom, getting at your question about how do we then convey what a multidisciplinary team has thought about in order to talk to the patient, it seems to me like we can work with a multidisciplinary team and still be the person who interprets the recommendations or the context or even the goals and downsides based on what the multidisciplinary team said. So I think we have a big role to play here. I want to make sure that, that we know that there are lots of people who can support us, especially people from palliative care, but many of our other people on our team can support us too.
Dr. McGee. Dr. Schwarze, a fantastic presentation. Thank you for presenting today and joining us and for stimulating us to be better. One of the things I'm always struck with in the conversations with patients, especially new patients with cancer in my field in thoracic surgery, is the transfer of information is robust. I mean, there's a lot of discussion we're having. There's a lot of information that we're hoping the patient can incorporate and think about and come up with a decision. How do we ensure or do better at transferring that information in the single compressed visit that Dr. Schulich was alluding to?
Yeah, so I mean, I think, are you getting at time? Like how much time do we have to get this done in that time? Yeah. So this is a pretty common question that I get, and I have two answers. The first is less snarky, so I'm going to start with that. So you know that pie chart I showed you with the pink and the orange? People will often say, I don't have time for this, and I'll look at that chart and say, you don't have time for what you're doing, right? So we really need to focus on the critical pieces of this. What are we trying to accomplish? Is it plausible? Is it valuable to you? And is it worth going through all of this in order to proceed? So those are the critical pieces that need to get done. I think best case, worst case takes a little bit more time. And here's my snarky answer, which is that I have been to lots of surgical meetings and I have seen people talk about like extended lymphadenectomy for this, that, or the other cancer, or, you know, stents with fenestrations all over the place. And I've never seen anybody stand up at the end of that talk and say, I love what you're saying, but I don't have time for this, right? Because if it's going to help the patient surgically, we tend to find that time. And so I hear what you're saying about talking to patients. I feel the same way, right? Like, especially when I'm on call, I'm like, just book it. Like, you know, it's just, there's so much tension on us to get things done. And simultaneously, I worry that when we say, I don't have time, that what we need to be a little more precise about what that means, right? Which is that, that maybe I don't get paid for doing these things, or it's not valuable to me in the way that these other things are. And I don't want to be super snarky. It's not snarky at you, it's snarky at us. And I think that the world that we live in looks at time differently. Like, you know, Dr. Schulich said, like we have these visits that are sort of artificially imposed of us around time. So it's a problem, and I can't change the incentives. And simultaneously, there's a wonderful anthropologist named Sharon Kaufman. She said, you know, patients don't need more information. They need more interpretation of the information that we have. And so we need to be judicious about the time, but we also really need to remember that these conversations are incredibly valuable and will probably help our patients and families do better.
One last question.
I'm in the transplant department. This question might not really have an answer. I don't know, it's something I've been thinking about for a while. So we've had a lot of new technologies obviously enter the transplant field where we're now putting organs on normothermic regional perfusion, normothermic regional perfusion or using pumps. And a lot of it, we still don't fully understand long-term outcomes or what we're looking for, or how much time, et cetera, et cetera. Given we're having, like when we consent patients in clinic, we're consenting them to receive an organ, any organ. We can ask them if they want something that's marginal, like Hep C status, but we're not telling them the degree of how well we think the organ is, from a perfect liver to a, you know, we're not totally sure if it's going to work, but we think it's usable in the situation. What are your thoughts on that, I guess? Because it's something I've kind of struggled with, where some livers we get are perfect, and then others we're like, well, this is good, but organ availability pushes you to try to use everything you can. But you're sometimes giving a patient hand-me-down shoes versus shoes that have been worn.
Yeah. So in the interest of time, I'm not going to give a huge explanation, but I do think that you can offer patients a choice between a perfect organ and an organ that has some uncertainty around it. And I think the way we have that conversation is to go through the downsides of each of those strategies, right? Because the strategy of taking an organ that's not perfect means that you might get an organ sooner, right? And so the downsides to that, or the downsides of waiting for a perfect organ, is that you may not achieve your goal, which is to live longer, because you've waited such a long time in order to get a perfect organ. And we can go through the different downsides of taking an organ that's imperfect or has more uncertainty around it. So I do think that there are ways to do it in a way that is much faster than what we're doing. And I will tell you that explaining NRP or all of these different things in clinic is probably not the strategy that's going to help patients and families understand the way you think about it. What you need to do is help them get a grip around what that choice is and how it affects them, not how the technology is playing out for you.